to blood loss. And then there's functional iron deficiency, where there is enough iron present in your body, but the bioavailability is decreased. And this is mostly due to the fact that in states of inflammation, your hepcidin blocks the ferroportin, and ferroportin is in your intestines and helps bring in iron and gets it absorbed. And if you block the ferroportin, then no matter how much iron is available for you to absorb, it will not be bioavailable for you. And so hepcidin is upregulated in states of inflammation such as IBD and a variety of rheumatological conditions. Iron deficiency is the most common cause of anemia in IBD. It's very prevalent in children. Up to 95% of children in IBD have iron deficiency, and it's definitely the most common extraintestinal manifestation of IBD. When I look at labs for iron deficiency, I always get an iron, ferritin, a transferrin saturation, a total iron, or TIBC, of course, a hemoglobin. And the biggest things that I look at to try to figure out whether someone has functional iron deficiency or iron deficiency anemia is whether the transferrin is high or the ferritin is high. If ferritin is high, they're most likely suffering from functional iron deficiency. If transferrin is high, that means that your body is really trying to increase the amount of transferrin that is there to absorb every possible little bit of iron that is there. If the transferrin is high, it means that you likely have iron deficiency anemia, and your body's trying to amp up the amount of iron your body can absorb. And likewise, if the transferrin is high, it means that there's likely low transferrin saturation, because there's a lot of transferrin, but not a ton of iron that is saturating the transferrin concentration. In iron deficiency anemia, the first thing that you'll see is elevation of RDW. This is then followed by a falling MCV. And then lastly, your hemoglobin and hematocrit will fall. With the ferritin, whenever I see a ferritin of less than 30, you know for a fact that it's iron deficiency, no matter what. In a patient who has anemia, the ferritin level threshold is much higher. That means that even if they're anemic, if they're anemic, their ferritin can be up to 100, and they can still qualify for iron infusion, because even a ferritin of 100 in the face of anemia means that you have low iron stores. The other thing I like to look at is transferrin saturation. If the TSAT is less than 20%, it also is a signifier that your body is in a state of iron deficiency, and then you qualify for iron infusions as well, regardless of whether or not your ferritin is in an ideal place or you're anemic. So the mainstay of iron deficiency anemia is make sure you figure out whether or not the patient has active IBD. More often than not, if you leave the IBD, unmanaged, the iron deficiency itself will continue to plague you, and therefore you really need to treat the cause of the malnutrition and the chronic blood loss. If there's active IBD, the patient will qualify for IV iron. It likely will lead to a greater response than oral iron, is much better tolerated, and leads to a much quicker reversal of the anemia. And if a patient, of course, has pretty profound anemia, make sure that you also concurrently will order packed red blood cells if necessary, due to the fact that it can take several months to get their hemoglobin bulked up even after iron therapy. So these are some of the different iron infusions that we use here at UF. It used to be that we would refer all of these patients out to hematology so that they can manage the iron infusions, but now our pharmacist will order iron therapy for us, and that way the patient can either get it concurrently with their biologics, not at the same time, one in each arm or anything, but if they're already going for the Remicade infusion, they can then get the iron infusions right after they get the Remicade. And so it's just a much better one-stop shop and convenient for the patient so that they don't have to see, another specialist just to get an iron infusion. There's 6 different iron infusions that we use. The first 3 are iron dextrin, ferric gluconate, and iron sucrose. The big thing that you have to notice the difference is each iron therapy comes with a different amount of times you need to give the iron in order to get to a ideal iron level in your body. For example, with iron dextrin, for the most part, it only takes 1 or 2 sessions to get to the point where you can recheck your iron and see if the patient has made a noticeable rebound. The thing that patients don't like about iron dextrin is that it can take up to 4 to 6 hours for infusion, so that's a whole day. It is the cheapest infusion, so most insurances will try to negotiate for the iron dextrin. Ferric gluconate is a little bit more inconvenient for patients because you need up to 8 full doses for treatment, so 8 sessions, and that's, in addition to the infusions the patient is already getting, so it might be a bit inconvenient. And then iron sucrose is the best for IBD patients. It's covered by most plans like iron dextrin is. It also is a 2 to 3 hour infusion time, so maybe a bit inconvenient, but not as bad as iron dextrin. And doses vary anywhere between 3 and 10 to get an ideal amount of iron for the patient. And then the last 3 iron infusions are ferraheme, injectafer, and monoferric. Ferraheme is a 15-minute infusion, so most patients prefer that. You're in and out. The starting dose is 500 milligrams, and so most patients will need anywhere between 2 and 3 infusions to get an ideal dose. But for whatever reason, probably due to the fact that it's a newer formulation of iron, most insurance companies will tend to require that you have an appeal in order to get the ferraheme, and there's a lot of denial issues. The next iron infusion is injectafer. It also is a very short infusion time, 5 minutes. And for that reason, probably it has potential insurance issues. And the doses should be separated for by at least 1 week. But for the most part, you only need 1 to 2 infusions to get an ideal amount of iron infused. And then lastly, there's monoferric. It is pretty convenient because you only need 1 infusion to get an ideal dose of iron. So you'll notice that the first 3 iron products are most likely cheapest and most likely approved by your most patients' insurances. However, these are the iron infusions that will likely take several doses to get an ideal amount of iron for the patient. And then the newer formulations are the ones that take less time, less sessions, but are most likely to be denied by insurance, unfortunately. And I just wanted to take some time to quickly run through something that I use every day in clinic. It's the CCFA anemia care pathway for IBD. This really helps me figure out the algorithm for when it's appropriate to give IV iron versus oral iron and when to recheck their iron levels. So of course, in all my patients, I will get iron levels as well as the hemoglobin at least twice a year, if not more. Typically, the first thing I do is figuring out whether or not a patient has low hemoglobin. Of course, right away, if they have ferritin levels of less than 30, then I know that they are iron deficient, whether or not they have low hemoglobin. If they do have low hemoglobin, the next thing I have to figure out is whether or not they have active IBD. If they have active IBD and low hemoglobin and low iron, that's when I immediately will sign them up for iron infusions regardless, because that of course improves outcomes, and that's the fastest way to get their anemia resolved, and especially if they need to be fast-tracked to see the surgeon and need possible surgery, that is the only way to go. If their ferritin is less than 30, of course, then I'll discuss with them. If they don't have any active disease, they still can, they do meet criteria to get iron infusions, but depending on how the patient feels, what their time constraints are, sometimes I will test and see if they respond to oral iron. But if they'd rather, get a quick turnaround with their response to their fatigue and help bulk up their iron more quickly, then I'll sign them up for IV iron, depending on what their preferences are. And of course, all along, I will also check for other causes of anemia, including B12, folate, so on and so forth. Once we have decided on either IV or oral iron, 4 weeks after they've started their therapy, I'll repeat their hemoglobin. If they haven't increased their hemoglobin by at least 2 grams from baseline, that's when we decide to either up titrate their iron, so either switch from oral to IV, or maybe do a couple of more IV iron infusions to see if their hemoglobin increases in 4 weeks. So just like with their IBD, I treat to target with IV iron or oral iron. I always make sure to check every few weeks to see if they've made a response. And if they haven't had a response, then I change something about the therapy. And so if hemoglobin has not responded appropriately over several months and I've made some changes, that's when I usually will refer them to our hematology colleagues, or figure out if there's something besides the iron that might be causing their persistent anemia. But I think the big thing with iron therapy is that treat to target, and then make sure you will completely reassess every 4 weeks and make sure that they're responding. And if they're not responding, refer to hematology. And always keep in mind that whenever you have an IBD patient that has active disease, they always meet criteria for IV iron, and don't hesitate to send them to hematology or order the IV iron yourself, because that is a huge cornerstone of treatment of their extraintestinal manifestations. So I'd love to know at your center if you do iron infusions at your infusion center, or do you usually refer to hematology, or how are things done? And do you feel like if you do refer to hematology, do they treat the way you'd like to? Do they treat to target? Do they use the IV iron that you usually want them to? What are your thoughts?
So for myself, I've oftentimes will refer them to hematology. We don't really have our own infusion center, so it's not something that we have access like right in our office. So if they are going to an infusion center for Remicade, we can do that, and they will go ahead and do the infusion. I do prefer the Injectafer.
Mm-hmm.
We do have the issues with insurance, but as soon as they have IBD and I put on their iron deficiency anemia, it's not usually an issue. But I mean, most of the time, our hematologists are pretty adept to do those infusions for us, and they treat to target, and
Perfect.
we have a lot of issues.
No, that's fantastic. That's definitely, we only started ordering our own IV iron about a year ago. Prior to that, hematology would help us out, but their bandwidth is only so much. And so I think it was a little bit quicker for us to order the IV iron along with the infusions. But yeah, no, I agree. Hematology does a fantastic job. Yeah, I've learned a lot about IV iron ever since we started ordering it on our own. And I agree, Injectafer is great because it's 1 or 2 doses, and it's a quick infusion, and patients seem to like it a lot. Yeah, and it's been rare. I know it used to be back when I was in training, patients would have a lot of anaphylaxis reactions to iron, and have severe issues with it. But it's been very, very few and far between that I've seen that. I think it's maybe one patient who's had hypophosphatemia, and maybe 1 or 2 who have had infiltration and reaction issues. But if that's the case, then we typically will switch to a different IV iron formulation, and things go much better.
I'm curious, why don't you usually like to do iron pills? Like what's
No, I think again, it's one of those situations where I always make sure I discuss with the patient what their preferences are.
Mhm.
If patients have active IBD, the oral iron is not going to be absorbed patients have in high states of inflammation, high hepcidin from their livers, and the hepcidin blocks the ferroportin, which prevents iron from being bioavailable. So no matter what, if the iron is even available for you to absorb, your body's just not going to absorb it if you have high inflammation. And so in cases like with active IBD, IV iron is the way to go. So because patients tolerate it better, oral iron often causes a lot of GI upset. It causes a lot of constipation. And so that, on top of all the GI issues that might be going on could kind of confound things. And so that's why I typically like to use IV iron. It just is quicker. The hemoglobin pops up much more quickly. And if a patient is, possibly being evaluated for surgery, that's something that we definitely want a quick turnaround with. Oral iron just takes a lot more time to make a huge change in your hemoglobin.
Okay, makes sense. Thank you.
Yeah, I think the patients really do notice the difference fairly quickly. So, I mean, their energy levels definitely much improved after even the first infusion.
Agreed.
Dr. Pham, can you hear me?
Yes, I can.
Just a couple of comments. So in practice, I agree with you that avoiding oral iron has actually been my standard for years. And sometimes it's difficult to convince patients who have taken oral iron without any side effects. But in a GI practice, it's common for constipation and upset stomach to emerge, and you never really know if it's iatrogenic or constitutive. Iron can also cause some esophagitis and even stricturing, which is a reason that I've tried to avoid it. Sometimes even ulceration of the esophagus. As far as IV iron is concerned, I've tried to convince my office manager to administer it here in the office. We do provide some infusions, and apparently there's a fairly high upfront cost. So I've not been able to convince her now for some time. So I'm glad to hear your advocacy.
No, I'm hoping, I hope that you'll be able to start giving IV iron soon, because I feel like your patients would really, really like that, because if they're already doing the infusions at your office, it shouldn't be too much difficult to add an iron.
Do you actually infuse it at the same time or before the Remicade?
Yes, we actually can infuse it so you do the Remicade first and then you do the iron infusions. We typically can't do it at the same time. So I guess what you're asking is if you can do an IV in one arm and then an IV in the other arm and give it at the same time. Typically we don't do that, but we do it sequentially.
Thank you.
I think a lot of that could be limited by the iron formulation that the patient is approved for. If it's going to be a formulation that takes, 4 to 6 hours, the Remicade probably already takes 2 to 3 hours. So that's probably the better part of a day. So typically we'll, divide those up into 2 separate sessions if it's, a longer iron infusion. But if it's only if it's just Ferraheme or Injectafer, then typically we can do it sequentially. Definitely. So I think since it's the holidays coming up, I would love to give you back some time and get some time back myself. I know we have a week left now, and I really, really have enjoyed spending time with everyone and learning more about you and your practices and sharing knowledge and collaborating in this way. Hopefully we can do another session that's similar to this in the coming months and next year. We'll see what things bring. If I can, couple together the bandwidth for it. I'll send out some emails if we're able to do a second session that's similar to this. But I really, really appreciate the time that you've spent with us and learning from each other and collaborating. And I hope you have a great rest of your year and have a happy new year if I don't see you before then.
Thank you. You as well. We've enjoyed it.
Thank you, everyone.
Thanks.
And I'll send out emails about the stipends as well soon.
Thank you.
Have a
Thanks,
great
Barbara.
night.
Have a good holiday.